We'll restart our sessions in Hall B. I invite Dr. Sara Bhattacharjee to moderate the session on Rural Sensitization Program and Travel Fellowship by Dr. Pravin.
Good morning. It's a joy for me to introduce our speaker for the morning, Dr. Pravin. I met Pravin many years ago in Sithilingi, where he was doing his rural service. Pravin did his undergraduate and postgraduate studies in Ops and Gynae from St. John's Medical College in Bangalore. The 2 years he spent in the Tribal Health Initiative in Sithilingi, serving his rural obligation, was a time when he fell in love with the place. So after he did his postgraduate studies, he went back there. Pravin is a practicing clinician. He has a focus on Ops and Gynae, but he does everything. But in addition to that, he has been anchoring the program which exposes medical students and young doctors to a different way of practice of medicine. These are the rural sensitization programs and the travel health fellowship, and he will be speaking to us about his experiences with that program. Pravin.
Am I audible now? Yeah, thank you. Thank you, Sarah, for those kind words of introduction. So my presentation has got a lot of slides, but no written matter in it at all. It's just got photographs from top to bottom. So I hope it won't be very boring. And so I'm going to be talking about the Rural Sensitization Program and the Travel Fellowship, two initiatives that we started as a collective. What we think of these things, these are not really programs, they're probably movements in the making. First, I'm going to talk about the Rural Sensitization Program. Yeah.
Can we request that after he does a 15-minute presentation, we take a break for questions on the RSP and then go on to the Travel Fellowship?
The Rural Sensitization Program is a 3 days live-in camp that we have in different parts in the country. So it's started as a project from Tribal Health Initiative where I'm working at right now. And in these 3 days, medical students from different parts of the country come there and spend 3 days in the village, have lots of discussions, meet mentors from the field. And then the idea spread, and now the Accord organization in Gudlur also conducts one, and Basic Health Services, Dr. Pavitra gave the previous talk, also conducts RSPs, and now Jan Chetna Manch in Jharkhand as well. So this is basically to explore doctors and medical students through rural life and the problems and the challenges of living in a village, and also the problems and challenges of community health. Why did we start? Because we realized that mainstream medical education does not provide the opportunities for students to experience the actual context of the health problems of the country, and especially of the rural areas. Our education is focused mainly on the mainstream medical knowledge and practice in large tertiary care hospitals, and very little attention is given to primary and secondary level hospitals. And there's also a great mismatch between the settings where education takes place, which is generally in the cities, and where the health work is actually much needed. And how did we start? We were inspired by the Nirman model that was brought about by Drs. Abhay and Rani Bhang. And we wanted something similar for the South. And that's when we came up with this. And also we see that there's been an increasing number of doctors who are dissatisfied in general with the trends of the mainstream medical education, and they're searching for alternates, in fact. And so doctors and students come into these beautiful villages in Tamil Nadu and Rajasthan and Jharkhand, and they see living models of change. And they see people working in the NGO sector and who do different things like interventions in the field of education, livelihood, food security, land rights, housing, governance, and also healthcare to the last village, to the last person in the last house of the villages. When you see this picture, this is a picture of the Sithilingi Valley. When you see this picture, what do we see? Like to a tourist, it looks like who's standing on top of the hill on the other side, or say someone is flying a drone over this valley or is going paragliding over this valley. What do we see? It's all like green farmlands, forests, birds, and little hamlets and little houses in the farms and rolling hills in the backdrop. What we actually don't see is farmers toiling in the sun just to get their children educated, to get their sons and daughters married. The lack of quality education, domestic abuse, gender disparities, obstetric violence, deaths, and deaths due to crumbling public healthcare systems, violations of human rights, and caste issues, to just name a few. Basically, the problems that a tourist cannot see because he or she is unaware is a product of privilege and is a product of the absence of such dire disparities. These are students who have no idea what they're coming for. So this is how a typical group of students, when they walk into the village, the only way they come there is by bus. And we stand in different bus stops and get into the bus when the bus stops there and say, anyone who's come for the RSP, get down in this spot. And then they start walking towards their accommodation. And they visit people in the field, they visit families, they visit farmers' homes, they visit basically what we refer to as patients. This first picture is from a visit in Sitlingi. The second one is from Udaipur, from Basic Health Services. They walk across water bodies, they go and toil in the farms with the farmers. They spend time with the farmers and with the artisans and in general, just people from the villages, and find out their stories. They visit their homes, they find out about their pets and about their families, and basically collect stories and just listen to them. And when they come back, they sit together and they brainstorm and they share stories of beautiful homes, of such strong women that they met, of well-informed farmers, and of difficulties and challenges of living in a village. Students who've only seen patients, for the first time, they see them as people. They get to know their names, and from then on, the conversation starts. And for the first time, they don't know them by their diagnosis or their bed numbers. After that, follow rich group discussions with the mentors from the field, and various conversations unfold about issues with the current postgraduate medical education, with super specialty based training, the toxicity and hierarchies of the medical system, and whatnot. The reason why people chose to be doctors, and how the medical system slowly and systematically dehumanizes us and glorifies a profession and puts us on an imaginary pedestal. These are all various things that come up in the conversations. And students often themselves deconstruct the whole doctor image that has been created and are left wondering, what is it really? Is it an imagination, or is it an image that has been created and that we are all being fed this? Are we aware of what the system is actually doing to us? And are we aware of the pharmaceutical industries that is driving a lot of our practices? And our labels that on our many packets and surgeries that say for one-time use only, are they actually real? When we get so angry at our patients who don't come for follow-up on the specified dates that is convenient to us, is it fair? Is it a fair system? And when they go to the villages and they talk to people and they ask about their lives and visit their homes and spend time with them and ask them questions about what are your top priorities? And people often say our top priorities may be food, shelter, education, and income. And this is an absolute shocker to medical students, because for young medical students who've been wondering that my entire life has been about healthcare, and I've spent lakhs of money about this, and I've been fed this, that this is the most important thing that the world needs right now, and this is a service to humanity, and that my entire life and my entire 20s has been wasted on this, and I'm not even one of the top priorities for people. And as a friend of mine, Dr. Ravi Narayan used to say, the minute we step out of medical college and we become doctors, the whole world becomes patients to us. And we ourselves often forget that we are also people, and that we also have the same inadequacies and the same human tendencies as the others. And why do we so easily laugh at the fact that doctors are the worst patients? How is that acceptable? And these are all questions that are hiding in the gray area of every individual medical student, but they've been quietened by lengthy exams and complex mechanisms of actions and classifications, fancy diagnosis, and niche medical jargon. For a simple example, how pyrexia of unknown origin, PUO, is actually, I have no idea what's happening with you. So basically, we try to demystify the whole medical curriculum. And we often find that medical students are brimming with questions that are full of confusions and anxieties and are left unheard in the busy medical college system, where individuality is condemned and commonality is encouraged. When a patient doesn't understand about his or her disease, is it due to the lack of comprehension, or is it due to the lack of our time, or is it actually the lack of our understanding of what is actually happening? Of course, we also hear about great stories of teachers who they've met in the medical colleges, often the ones who've gone that extra mile, or the ones with the personal touch in their work, or the ones who will teach you things by them just being. In these smaller group discussions, we also discuss about the expectations and anxieties of working in a rural area. And we all know that 68% of our population still resides in the villages, but over 70% of our doctors live in the cities alone, fighting to find a place in the complex system. We are in a system where once upon a time, doctors right after MBBS were doing things like birdholing and ENT surgeries and running hospitals. But right now, MBBS is just treated as a prolonged PG entrance preparation, and PG is considered as a pre-super specialization, and super specialization is just a pre-foreign fellowship. And we are made to feel inadequate at every single level. And this is not a problem with individuals, it's a problem of the system. And what we need is a comprehensive overhaul to align medical education with the needs of the country and the goals of universal healthcare. Well, these are all big words. And what can we actually do, and where do we start? We can at least start the conversation. As doctors and healthcare professionals, we are unaware of the current happenings of the country, of the various policymakers in whose show we are just mere puppets who are just dangling and dancing with invisible threads. This is a picture from the RSP that happened at Jan Chetna Manch in Jharkhand, which is an organization started by a women's self-help group along with dyes and midwives, and they introduced this whole concept to the world of social obstetrics. And these were the various group discussions that happened later. This was a session that happened in Sitlingi where the first spine surgeon from India, he visited our center, and then they started performing spine surgeries in Sitlingi, bringing their team of doctors and nurses. And when they went back to the villages to visit the person that they'd operated upon, and this was a man who was bedridden, and they'd done a spine surgery. And 1 year later, when they went back to his home, the same man climbed up a coconut tree and plucked coconuts for all the students who would come to his house. This was a sensitization program that happened at Gudlur. Again, a different place with a different context and different issues. But what is common in all the RSPs is the informality and how low on structure that it is. The various rules that we have for RSPs is that everyone should and can speak in any language that you are comfortable in, and ask whatever comes to your mind, and forget your prefixed labels. And also keep the structure really low. If the students decide that this afternoon we don't want to do this, we'd rather take a nap or walk in the forest, they're allowed to do that. And this is a picture of one of our evenings where at dinner, the students just come there and make dinner for everyone. And many of these people you can find here in the audience also. And also, of course, we have really inspiring mentors who come there and give us really short and crisp and inspiring speeches which leave us speechless and keep us thinking for many months later. This is Dr. P. Singarayar talking to the students. So what have we achieved? We've had close to 20 camps in the last 5 years, and about 500 students have attended till now. Every time we send out posters for the RSP, about 150 to 200 students apply, but we don't take generally more than 30 or 35 in a camp, because otherwise we lose the personal touch and otherwise it becomes a classroom. And it's mostly medical students also sometimes mid-career professionals, nurses, MPH practitioners, Ayush practitioners, physiotherapists, and whatnot. And what we aim is actually just a change in thinking. A lot of our students regularly keep in touch and they write to us and visit us quite often. Some of them join our hospitals, or at least they have this experience in their mind the next time they look at a patient. They all write letters to themselves at the end of our RSP camp that we post to them 1 year later. Although it started off as an experiment, in our opinion, this is a major movement in medical education. So these are various camps. The first picture on the left is from Gudalur, and then on the top right is from Jharkhand JCMB. The bottom ones are one from Sitlingi, and the next one is from BHS Rajasthan. So I thought it'd be wiser to take a break now instead of just going on with the slides. So
Are there any questions about the RSP or comments? Will you keep a 5-minute time? It's a question. 6 years are spent dehumanizing a medical student to make her a technical expert. Why can't RSP be inserted within the 6 years?
So in the audience, we also have a lot of our travel fellows and doctors who worked with us in all these organizations. And if anyone wants to answer these questions also, I'll be very happy. So we had this discussion at some point whether this should be made a part of curriculum. And then we realized that a lot of medical colleges already have this as a part of the curriculum, where they have, like a secondary hospital posting or a rural orientation program. But because of how complex it is to deal with so many students, and the very ingrained part in us that we have to have some structure in it, where students go to different homes with questionnaires and ask them about their toilets and where the mosquitoes come from. And because of that, we realized that such sort of an informal a conversation cannot happen in a medical college, because all our medical colleges, however we like it or not, are full of structure. And when we break that structure and we bring it down and make students sit on the ground and have open conversations and also share the inadequacies about ourselves with them, is when these conversations really open up.
Any other questions? Yes.
Just wanted to ask, do you maintain a database and continue networking after they leave this course, and as to where they go, what they do in there, and is there some sort of documentation of that?
So we are in touch with all the students who attend these camps, but we don't really regularly follow up with them. Because we are also a very small team which is doing the clinical work and the hospital running of the hospital and these camps. So just off late, just 2 of our doctors said they'd like to follow up on what these students actually think about it years later. And they've been following up with a few of its students, but till now it's not a structured thing that we do.
So just to follow up on that lack of structure that you talked about, which I think is great, but I think the last time our college, we have secondary hospital postings where we do send them to different places, and I think the last time we tried to keep it as, less structured from our side and more dependent on whatever the organization wants to do. But sometimes I find that there can be a balance between the student, like if he's left, there will be some students who are very driven to kind of utilize that time like to the best of what they can get from that place. But there will be also another set of students who just would not really use that resources as much as as much as they could. So would not structure be a way to kind of balance this out? Not like not to create that it has to be in the structure, but to at least create some sort of a pathway so that so that if somebody comes to Sittlingi and just sleeps in their room for 2 straight weeks, it's kind of going to defeat the entire purpose, right? So I mean, but this is, I mean, again, it comes back to that in collective versus individuality kind of thing. So I mean, how do we kind of sort for that? Because in medical colleges we have 100 students, 150 students. So
Yeah. So, yeah.
So, okay, I'll just add on to that. I mean, I'll just make a remark about that before passing on to Pravin. So, I have observed sometimes when the students come for this posting, they will have to take a photograph of a patient using an inhaler, and they'll have to get some label of a medicine that they use. So their entire focus will be on making sure that that data gets filled up. And I think the focus may get shifted. And what you said is right. I think when you have a class of 100, there is always a possibility that some people may slack off. But I think one difference here is that those who apply for RSP are the ones who are already motivated and who are seeking. You can't expect, but what I'm saying is that when you try to make it such a structured thing, even those who are seeking may lose out on it when you're trying to make it so rigid is what I feel. But yeah, back to you.
So why we kept it very low on structure is that for the people who really want to explore it and learn, it will definitely reach. And for the people who really don't want to listen to you, however much you try, it's just not going to reach. And also in the beginning, the students who came there had no idea what they were coming for at all. They thought it was like a 3 days of clinical exposure. They thought they'd get to assist in surgeries and different things. But of late, the news of the RSP across India has spread to many people that they know what they're getting into. They know what they're coming for. They know that there's going to be a change of mindset after they come there because they're going to see an alternate reality. And also, just like how village practice is not for everyone, the same holds true for city practice. It's not for everyone. And this is just showing them a different alternative. So this for people who are very like completely dissatisfied with what is happening in the medical colleges or in corporate hospitals or nursing homes, and just to show an alternative that this is also possible.
I think when we started, the one big focus or word we used was, this is not college, it is un-college.
Just a comment from a CMC alumni. I think what medical students probably can expect in a medical college setting during the undergraduation is the availability of a mentoring group within the medical institution. So if there is a medical student in a batch of 100 who says, I'm someone who would like to work in a rural setup, I know there is a group of people who have lived the talk, and I can approach them and think through things with them.
Yeah, thank you.
Shall we go on?
And about the next part of the presentation is about the travel fellowship that we started. The RSP, the Rural Sensitization Program, is what we consider a nursery ground in which saplings of travel fellowship is grown. And what do we see in this picture? It's a fancy doctor's office. And the other picture is of a typical medical college teaching session. As medical students, we're all thrilled when we first learn about the human body, about the different investigations, the surgeries, x-rays, and all of that. And one can spend one's entire lifetime trying to learn all of this, but still at the end of it, we will never know it all. We get so immersed in this ocean of knowledge that we forget what we wanted in the first place. When doctors pass out, sometimes dissatisfied with the system, they wonder what to do. And that is when they hear about this travel fellowship and think, why not explore this? And as Sarah just said, we call it the un-college approach to medical education. So in the next series of slides, we'll walk with the travelers as they embark on this journey of self-exploration and personal growth, walking through farms and forests and through marshes and swamps, treading on lands and waters very rarely treaded upon by doctors, and walking through some of the greatest landscapes of the country and become a part of different cultures. As they find themselves entangled in the middle of a complex web of social determinants of health, lack of healthcare, marginalized populations, policy deficiencies. So it is a one-year program where students from the RSP who attended, they said 3 days is too short and we need a long exposure. We want to really explore into what this is. And that's when we came up with this idea of the travel fellowship, where people post either MBBS or after post-graduation, or many times even in the middle of their careers, decide to take a break for a year and really explore what the actual healthcare system in the country is all about. And that's when they start this journey about the travel fellowship, where they get to visit similar organizations across the country and spend about 2 to 3 months in different organizations. And so they cover 3 to 4 centers in a year. So we formed an informal group of similar-minded organizations from different parts of the country, like in Tamil Nadu, Chhattisgarh, Jharkhand, and many other places, and called it the Rural Healthcare Collective. And these are all organizations with different contexts and different issues, but with a common goal in mind, a step closer to health for all. And we encourage our travelers to go to these areas alone, unaccompanied by other travelers, because even if they go with one other doctor, most of the conversation only happens between the two of them. And so we encourage them to go to these places alone. And they get to travel by buses and trains and tuk-tuks and reach the remotest villages of the country, to places where they do not know the language or the people or the food. They live there with the people. They witness unheard of stories of starvation, of bashed up wives, of neglected pregnant mothers with hemoglobins of 3 and 4, with stunted teenagers, unattended occupational health hazards, and playful children with severe anemia and massive spleens just running around. These are doctors who had the same training as all of us. Many of them have seen migrant workers in their cities or in their streets, or even had in their own homes as they're growing up. And for the first time, they go to these migrant workers' hometowns, and they see what really happens to their pregnant wives or their husbands, to their debilitated parents, to their starving and poorly educated children, their barren farmlands, and the overcrowded trains in which they have to travel. And many times in which, in different directions and axes in these trains, there are humans dangling in all directions. So these are some of our fellows where they've gone to villages in Gujarat or in Chhattisgarh or in Kodaikanal Hills. And they've also volunteered in the local schools, played with children, had painting sessions with them, and driven across rivers and conducted village health camps. Basically, the motto being, let's get our feet dirty and our minds enriched. There's a camp where they're reaching the last village in the lower Kodaikanal Hills, in a village called Kesipatti, and setting up a small outpatient facility there. And these are pictures from Orissa, where on the road, mostly, as one of our friends, Sangeeta, used to say, there was no traffic jam, there was just a lot of goat jam. And doing physiotherapy sessions with the health workers there, conducting OPDs in the villages, taking medications to places which are at least 3 to 4 hours away from the main road, and teaching health workers about things like basic life support. They also get immersed in a rich cultural experience, where they go to villages where they have different practices, different customs, and different festivals, and they are very openly welcome into their traditions. And they also get invited for their weddings and other festivities as well. This is from Garba in Rajasthan, and the other pictures from Pongal in Tamil Nadu. What we do at the fellowship is that it is rich, it is mentorship rich. At the beginning of the fellowship, we have a 1-week orientation that happens in either in Sitlingi or in one of the places. And after which the fellows, the travelers we call them, they start on their journey. And 6 months later, we have a mid-fellowship reunion where they reflect upon what happened in those 6 months and then what is the way forward for the next 6 months. And by the end of the fellowship, there's also another week that we spend with them, and where all the mentors and all the travelers get together and reflect on what really happened in that 1 year. And there is no expectation from any of them that they have to join a village hospital after this or start an organization or anything. But we can clearly see that there's been a major shift from when we met them 1 year ago. And during these meetings, there's also a lot of trekking and swimming that happens, and a lot of stories to share. Sometimes through presentations, sometimes to just videos or songs or poems, sometimes through just painting. And these are typical sessions that happen. So we don't have any assignments that they have to submit, or they have to have done so many clinical procedures or have to have visited so many homes, and no logbooks of any sort. Every traveler is allowed to explore as and when they want and how much ever they want, and in whichever field that they want. They don't even have to be in a hospital the whole time. In fact, you had travelers who spent just 1 month in the clinic when they come to, say, Sitlingi, and then the other 2 months they've spent 1 month in the school learning to translate things from Tamil to English, and the other month with the livelihoods project and different things like that. And basically the sessions, most of the time, they just share photographs and then stories unfold from then. So that's why all our meetings are at least 1 week long, because with each traveler, we take an entire day. They share one photo, and then from there, everyone starts sharing stories, and such deep conversations unfold from there. And sometimes the session happen outdoors, and different conversations come up about how, what kind of disparities there are in our own lives compared to theirs, and the cost of living that we have. And we do see people who are not able to afford 5,000 rupees to go to a bigger hospital, but our train ticket would easily be more than that, or the clothes that we buy for Diwali would easily cost way more than that. So where do we draw the line? Where do we decide that, no, I'm not going to give this money, or should I give this money? And different doubts come up in people's minds. And also, what does it really mean to have a home? What is home to these travelers was something that we always ask the travelers. And always by the end of that 1 year, they say, I don't know what home is anymore, because I feel like I have homes in every single part of the country now, and I have a family everywhere. And although it's mentorship rich, the mentors also get guided by the fellows. There's also a lot of learning that happens from the travelers that the mentors also get. And mind you, these are not health tourists. They're not sightseeing and photographing just poverty or anything just to display on Instagram. They're becoming a part of the society, and they see how oppressed people are, and in many ways, how we ourselves are the oppressors, and how we ourselves are a part of the system that makes us the oppressors. This is a picture of one of our travelers, Sandhya, who's here. She, during her fellowship, so during the fellowship, they can decide how long they want to spend at which organization and for how many days. And she decided to go with the relief team from organized by CMC to go to Manipur and help with the displaced population there. So we meet often. At the same time, we also make sure that there are prolonged periods where we have no contact, where they have to live by themselves and figure out things for themselves. And when we are not able to meet, we meet online and share stories. And this was an exercise that we did last time, where we drew a map of India, and every traveler was given a different colored chalk and had to map out where all they went in the last 1 year, and the map looked full. So what is happening is that because of decades of suboptimal investment in healthcare, a lack of political commitment to the ideal of universal quality healthcare, and absence of comprehensive strategies to address this, there are glaring inequalities in the health outcomes. There's also been no system in place to incorporate health, nutrition, education, social safety, gender, social equity, all as critical inputs to economic development. We think these are all different departments. And policies focused on tertiary care are expanding just private sector's role in healthcare delivery, and very little attention is given to primary and secondary care. And according to the 2020 WHO report, what we need is a minimum of 44.5 health workers per 10,000 population in India by 2030 in order to secure universal quality healthcare. But we are nowhere close to that. The Medical Council right now registers 12 lakh plus doctors in the country. That is approximately 7.76 doctors per 10,000 population. And there's not just a shortage of doctors, but of different healthcare professionals like nurses, midwives, and physiotherapists and dentists and whatnot. And because of this shortage, it is only natural that this gap is filled by unprofessional workforce, like the untrained medical practitioners, faith healers, bone setters, and pharmacy outlets. And this gross inequality has barely been acknowledged by our medical system, let alone be remedied. You may think, what is this one doctor going to do and what is he going to change? But currently the country has one MBBS seat per 14,000 population, and probably much worse in the villages. There has been a tremendous increase in the number of doctors in our country, but are we making India a healthier place? That is, we're not sure. Like after the Italian unification, one of the nationalists said, we have now made Italy, now we must make Italians. India, because we all know, is a conglomerate of many countries, like a fisherman in Kerala and a tribal lady in Arunachal walking on snow and a Kashmiri Pandit are all fellow citizens. It is a country of plurals, and it has always been like that. And 75 years post-independence, we cannot blame the colonial legacy for the sorry state for the healthcare system that we are in. And setting a curriculum and pedagogy appropriate for the Indian health context is what is the need of the hour. And we think our fellowship is one step closer in that path.
Sometime.
I'm just 1 minute.
Yeah, sure.
So I'm just going to show some the different centers where it's happening. So the RSPs happen at THI Sitlingi and Ashwini Gudlur, Basic Health Services Udaipur, and Jan Chetna Manch in Bokaro, Jharkhand. These are also centers for the travel fellowship. And the next upcoming RSPs are going to be held at a center in Dangs, which was started by our travel fellows who went and started the center in tribal Gujarat, and Arohi in Uttarakhand. The other travel fellowship centers right now are Jan Swasthya Sahayog in Chhattisgarh, Swasthya Swaraj in Orissa, Bisum Katak in Orissa, Shahid Hospital in Chhattisgarh, VGKK in BR Hills, Tunnel, an organization that works with carbon neutrality, and they've made an entire panchayat carbon neutral. They are one of the organizations. Pain and Palliative Society in Thrissur, and KC Patti in Lower Kodaikanal Hills. And for this, I would like to thank all the travelers and the mentors from the field and the distant mentors, and of course to Paul Hamlin Foundation, which is funding us to make this happen. This is a short write-up by one of our travelers that I'd like to read out. Will my baby be okay? They ask anxiously. Latki ya latka? Latki. Yeah, then don't worry, she'll survive. Listening to this conversation unfold, I began to smile at this statement, but my face fell in dismay as she continued. She'll survive because she has to. She has to be strong to endure the starvation and the beatings and the thrashings. I wanted to hide my face from this brutal truth. It was no fault of hers to be born a girl in this cruel world. It was no fault of hers to be ignored by the caretakers assigned to her by nature. To be starved, to be malnourished, to be stunted physically and mentally. Does it get better at all? To be denied education, or to the few who do receive it, to be told you're stupid as she struggles to keep up, even though it was no fault of hers at all. And to finally drop out just to be sentenced to marriage, even before she's allowed a chance to ever step into adulthood. To be charged with one important mission, to birth a son. God forbid a baby girl be born, lest the cycle repeats once more. But of course she will survive too, because she has to. This is the last batch of travelers who are now starting on their journey through these extremely challenging roads. but to never forget that they always have a friend in hand. Thank you.
Thank you. We can take a couple of questions. Any questions or comments?
Hi, why is it limited only to medical doctors, and do you plan to extend it to other healthcare professionals or allied health professionals?
Again, a discussion that we've often had. Even we agree that healthcare professionals is not just doctors, and there is a lot of need for all sorts of healthcare professionals everywhere. But one thing was that, again, like I said, we are a small team trying to do this, and our forte is with doctors, and with handling with other healthcare professionals, we do not have the adequate experience. That is one, and for the mentorship especially. And the other thing is, last year when we were thinking that maybe we should open up to all healthcare professionals, we thought initially let's open the applications to just doctors, and we received 85 applications last year, and we take only 5 a year because it's mentorship intensive. So that is one reason. Otherwise, nothing personal.
Thank you.
These are our websites, the travel fellowship program designed by Vanya, our current coordinator, and the rural sensitization program. And I'd also like to introduce the rural hospital network, where doctors and all healthcare professionals can find vacancies in different rural hospitals across the country.
Yeah, if
Hats off for this great initiative, because creating a space like this and sorry, emotional, and making them feel what people need is much important than just working with the machines and medicines.
Thank you.
actually, when we did the RS space, we wanted to open it up to even engineers. But again, we felt that we didn't have the expertise to do so, and the numbers. But we do get engineers, architects, educators to talk to the students. Yeah, if there are no more questions, thank you. And,
Oh, so thanks, Pravin. So in the RSP at Jharkhand, when we did have a mix of people other than doctors. But some of us realized that we do get very medical intensive in the discussions, and we may be leaving out the non-doctors. That was one thing that we thought, and it's again, like Pravin said, nothing personal. And we also felt that because they are in a position to lead, just because of the hierarchy or the way the structure is designed. So at least let us start with the doctors, and then spread out to other professionals, so that they become better examples for the other. And it's still experimental phase, so we might branch out to other professionals also. Thanks.
For those of you who've not met the travelers who are here, Sandhya, if you can say hi. Yeah, Sandhya's the one who she's the one who wrote the account about the baby, a girl child. And Vasu, who just spoke, she was a microbiologist in Stanford University for more than 15 years, and then decided that she actually wants to be in India in primary healthcare. and started the fellowship in the first batch. And she's still continuing to travel after 4 years and won't leave us alone. And Vanya is our coordinator. Okay. Yeah, thank you.